there's a tendency, a natural tendency, to reduce medicine and medical care to like this mechanistic fixing of things, because that model is just so super powerful, right? The body as a machine that needs to be fixed, it just works. It can't stand alone, right?
We're talking about machine learning and AI and so forth, and also things like vibe coding that have hopefully made it easier for people to build in this space. That being said, the other limiting factor is how well the entrepreneurs and developers and other builders out there actually understand the problems that they want to address. How well do they understand the nuances? And I think, as we'll talk a bit about today, can we get past this idea that everything is just about reducing time spent on an activity and efficiency? You know, can we graduate to a better understanding of the problems for those that are building? So that's my way of justifying using all of your time today, and also setting up why I think hopefully we'll do more and more of these discussions. I think just to get us into it though, I obviously don't have experience as a healthcare professional, but each of you do. So if we can just establish kind of who you are and what your backgrounds are. And Lasse, you've done this a few times, so I'll pick on you first, if that's okay.
Yeah. Well, my name is Lasse, and I have a background as a medical doctor, and I've worked as a clinician in full-time for 14 years, all in all. And I also had some more years before that as doing sort of assistant doctor and nurse assistant work during my studies. So quite a long time I've been in this space. And right now I am working full-time in Corti as head of clinical innovation. My specialty as when I was a clinician was abdominal surgeon, or gastrointestinal surgeons, intestines, liver, gallbladder, abdominal wall, and things like that. So that was elective surgery and emergency surgery. But it's also very broad internal medicine, because people show up with the existing problems in addition to whatever surgery they have. So it's very broad. But now I'm transitioned to this world.
And you've been with us a little while now? How long
Yeah, I've been with Corti for a year and a half now.
Okay. Yeah.
Yeah, exactly.
And you've made your mark.
Maybe, yeah.
Things are much worse.
Yeah, I know. I've tore it down. Yeah.
Should we go, Laura?
My name is Laura, and I've been a nurse for 8 years. Specialist in neonatal care, intensive care for pediatrics and small infants. Mm-hmm. So I know a lot of small children and the birth and the whole family as something very special and unique, I think, in healthcare. Because in neonatal, we take care of the whole family, not only the child, because the parents are also living in the department as well. Yeah, neonatal departments are like, I always think of it as the whole hospital inside one department, because you have heart diseases, you have lung diseases, you have all the things. You have departments for each disease in the rest of the hospital, and in neonatal you have all that in one, because it's just the smallest children.
That's the factor that brings them all there. So long as it's really small children,
under
then they're
2
in
years. Yeah,
under 2 years. Okay,
yeah.
Interesting. Vanessa, who are you?
Yeah, I'm Vanessa, originally from Norway. I have a background as a medical doctor with a background in neurosurgery. And I've been abroad for quite a bit. So recently returned to Scandinavia for about 3 years ago. Also done some research. Don't have a PhD as Lasse does. But
does he mention that a lot?
Sometimes.
Yeah.
Not every sentence. Some of them, yeah.
So today, I think we've generally focused our thinking before we started recording on the concept of kind of human experience, which sounds very, very fluffy. That's why I'm allowed to say it as a marketing guy. But human experience being like from the healthcare professional point of view and also the patient point of view, and how, I don't know, maybe sometimes that gets either just not considered or dismissed in a discussion that's otherwise all about artificial intelligence and efficiencies and, you know, speeding up the process and automation and so forth. As I set up in the intro to this, honestly, I do feel, especially since I've lived in Denmark, Every time I'm talking to, now I'm thinking mostly my GP, I feel like time is of the essence. Like I'm there only to talk about whatever I booked the appointment for.
Yeah.
If there's something that I think might be related, if I'm not confident, I won't mention it. And it just feels like the quicker I can get out of the door, the better for everybody, right? And whenever I leave, I go home and my wife says, "You seriously didn't mention this?" And you didn't mention, you know. And I don't know what success looks like. So maybe let's start there, Laura, with like the points of the consultation can't be how quickly did we get it done, right? And that's where, at least on the technology side, we sometimes think about it. So what else should we be thinking about when it comes to the patient healthcare professional consultation that is not simply how fast can it be?
I think most of the conversations about AI tools and healthcare is about efficiency and how we can get time back to the clinicians. And I actually love that we can do something else as well, because we actually now have a pilot test in a region in Denmark where the clinicians and the patients are saying, oh, now we feel like we have some connection with the clinicians because we are looking them into the eyes instead of them typing at the computer. And I've experienced that as well myself with a doctor just typing, looking into the computer and me trying to say my symptoms or whatever. And it was like, I could just call you maybe instead, because you're not here, you're not looking me into the eyes. And I think it's very important we remember when we're talking about healthcare, it's not only health, it's also care. And that's a big part of the relation between people. And maybe it's because I'm a nurse that this is very big for me, but it's important that we have these relations and we have this connection with other people's, because else we get lonely or else symptoms get worse because we're not feeling like we're being heard. Then you just draw with a bigger pencil or something because you need to express the symptoms more to get heard. Or
it's more than just that it feels nice, right? It's
exactly.
It's not just like it's a nicer experience.
Yeah.
There's actually, if I understand what you're saying correctly, it's that if you're not taking a moment to pay attention to what's going on, then things are missed. So it's more than just that it's like a nicer experience for the people.
Yeah.
It reminds me, I think actually in the Danish medical oath as a doctor, I don't know if it's perhaps international, but there's like the one of the things is to sometimes cure, often alleviate, and always comfort. That's part of the oath.
Sometimes cure, often alleviate.
Yeah, and always comfort.
Right.
That's part of the oath. And I think it's beautiful. And that's exactly what you're saying here, right? So this human connection is really important in order to feel that you're actually being helped. You're not alone with whatever medical problem you have. So sometimes there's a natural tendency to reduce medicine and medical care to like this mechanistic fixing of things, because that model is just so super powerful, right? The body as a machine that needs to be fixed, it just works, but it can't stand alone, right? You need that human connection to feel safe in it also. One thing is this human aspect of helping your fellow human beings, right? But another thing is also, in order to, for example, if you prescribe a medication that you want the patient to take every day for a week or a month or the rest of your life, in order to actually make them take it, you need to have a shared understanding that it's important. Maybe the patient doesn't want that, or maybe the patient doesn't understand that, and maybe you misunderstood something. So you need that human connection and understanding of the person who has I don't know if you medicate a hand for life, but to have that the understanding of the person who has the body, in order to actually make effective therapy. It might not be possible to treat people.
I think sometimes the conversation is turned to nurses being someone just doing different tasks. And we can help nurses with medication or something, just throwing in some robots. But if you haven't seen what's really going on between a nurse and a patient, then I can understand you can think you can just threw in some robotic technology, but there is something with in the meeting between the nurse and the patient that's so important for the patient to take their medication, for the patient to express their symptoms in the right way, or it's just it's really important.
Yeah, also the patients are at their most vulnerable state.
Yeah.
Which makes it even more important for actually a human, or to have that human contact.
Yeah.
And you mean practically as well, right? So you're, somebody said this once, that it's like an information extraction moment. It's the information with which you'll make a decision, the consultation, I mean, and the quality of the information that you get from the patient, like how comprehensive it is, and whether it's true, and whether they're telling you sort of things that might otherwise they didn't want to express. That's what you mean, right? That it's, if you're having a decent connection with them, if you're taking time, and if they trust you and so forth, then practically you have more reliable information with which to then make a diagnosis and so forth.
Yeah. And I think what you say there also is an interesting bridge to the AI, where we can have a tool which with Scribe, taking all the documentation from everything what is said during a consultation or between a patient, doctor or nurse interaction. But a lot of it is also, reading between the lines and understanding what the patient maybe isn't saying with their words, but, with their body language. And that's also another thing, or important thing to consider, I think.
Can't robots do that though?
Maybe at some point. Have a camera look at the patient and analyze the body language. Maybe have a sensor feel the temperature of the skin and gauge how many micronewtons of pressure they're putting on the abdomen, and looking at the facial expressions at the same time to see how painful it is. Maybe, but we're not quite there yet. And I have a feeling that there's a bit of a way to go there. For sure, we are going to be having some tools that can analyze certain sounds and visual impressions, but I think it's a little bit difficult to tell how fast that will happen, and it might not be possible altogether. And for certainly not the case right now. Right now, it's absolutely the human in the room who needs to be there to understand this.
So I just want to ask, and I know that we're talking about very different contexts, so we'll see if we need to get into the weeds, but how protected do you think those consultations are today? We talk about technologies coming in to make healthcare professionals be able to potentially see more patients and add to their workload, or at least reduce the administrative burden associated with it. But if we just look at today, the status quo, is there what's the experience like in your experiences? Do you feel like you have enough time with patients? Do you feel like you can engage with them? Or do you think this is its own problem that needs to be addressed?
I think sometimes there's enough time, and sometimes there's enough focus. What can be really difficult, especially when you're on call, is if you have phone ringing. And a lot of urgent things you need to do, and the phone keeps ringing while you're trying to do these urgent things.
I think there's also a big difference between if you're on call with these acute situations, or if you're in the outpatient clinic where you actually have a fixed schedule with a fixed amount of time for every patient. Because in these acute settings, if you have a lot of phone calls or at the same time as you have to see a lot of patients, then what you end up with at the end of the shift is all the documentation. And, usually then you have just been, writing some things down maybe on a paper, and then you have to go back. While in the outpatient clinic, time is also of the essence, as there is another patient waiting, or you have to be done within this time.
As just before we get too sort of nihilistic, is it just simply that you can't have a functioning hospital, let's say, without all of the healthcare professionals multitasking and being able to kind of drop one job if something is prioritized? Is Is it always going to be that way?
Well, patients are chaotic, right? When we have a lot of patients at the same time, they have needs at chaotic intervals. And I don't think if you were to plan in a way that there would never be any kind of strain on the staff, then you would need a huge surplus capacity of people just sitting around waiting. Am I right?
Yeah.
Also, there are so many unpredictabilities.
Yeah.
Right.
You know,
So
you
that's
can never
why
plan for everything that can happen.
But I also think it's important that people working in healthcare actually maybe love this part of their job, that they are not going to a shift and know exactly what's going to happen. It's also a big part of the job.
That's a good point.
Yeah.
It's a very good
really
point.
good point. I know a lot of colleagues who just love that. When there's
Exactly.
so much stuff going on, it's just so interesting, all of it.
Yeah.
I miss that a little bit.
You do?
Yeah.
I
But
don't.
sometimes when we have something in the office, like an incident or
Yeah.
something, it's like, okay, now. Like,
I'm ready.
I'm ready. Just push the button.
I can spill my coffee and stuff. From time to time. You're like,
And then there's a different environment where people are leaving for lunch or going for coffee, and it's like, no,
Well,
stop.
I got it during my first week. That was nice.
Yeah.
Some urgency.
yeah. What
I
was
love
that?
that urgency. Yeah.
With the, the big meeting we had the first week.
Oh yeah. Oh yeah. That was a little bit of urgency there. Yeah.
But that was nice to
Yeah.
get some of the
We
an acute situation.
We do get a little bit of urgency checks sometimes.
Yeah.
That's true, but it is still. And one of the things is, it's typically not in the middle of the night, except for the platform engineers, right?
I just think it's the feeling of everybody working together, everyone lifting where they can, and that's just a very, it's a nice feeling. I think.
feels great.
Yeah. And I also maybe think that sometimes there's not alignment between healthcare professionals and like managers. Like, for example, the pilot test I was talking about before. The first week we were evaluating, the clinicians were saying that they had a better interaction with the patients, and the patient had noticed that as well. And the first question the managers was asking was, what about the time? Did you reduce anything? And there was some misunderstanding about what I think they really want the technology to do for them. We really need to focus on what the clinician actually also wants and what is suitable for their workflow, instead of just like, where can we get speed, or if cut people head counts or something like that instead. I know we have a problem with less healthcare professionals in, just see, we are not there anymore as well. So I know that's a big problem, but it will also be nice if the conversation could turn a little bit into what else is there of good things we can get out of this.
It's related, right?
Yeah.
I wonder when we talk about this if we're talking too much about the kind of edge cases in terrific healthcare systems like the one we have in Denmark, where most people have access to healthcare, and we're talking about how can we make it even better healthcare. And related to that, I know that in rural communities in Australia, where I'm originally from, generally just don't have access to anything. And then virtual care comes along, and all of a sudden you can have mental health consultations and so forth that previously were just never going to be available in such small communities. Isn't the real problem we want to solve that more people get access to decent healthcare, rather than how do we make sure that every healthcare consultation is perfect and protected and even considers some of these human experience factors?
In conflict, those two things, improving the quality of high resource environments and making things available to places where resources are not high. Maybe they are in conflict, but I'm not quite sure. They don't necessarily have to be, do they? Telemedicine is a great example, right? It breaks down this barrier of distance, right? There's also some trade-offs with telemedicine. Like what did you say with the the wound nurses that you can smell the
you
wound.
You can smell. You need to use all this
Can you say that?
It's a problem. Like was it in the beginning of telemedicine? Wound nurses missed that feeling you have when you enter the room. You can smell things. There's something about being in the room with the patient that's different. The touch of the skin and so on. But you also brought very good skills out to patient that would have not benefit from getting into a car and going into the hospital and so on.
I think also depending on, the reason for the call. Say, a post-op consultation, you already know the patient from before. You had the interaction and then, everything went well. So you then have a consultation, 1-3 months post-operative. There, I think it's totally fine. Also, if a patient just needs a new prescription for a medication he has been on for a long time, you don't necessarily need to, do a full examination for the patient to come in.
Lasse, you were talking about this kind of psychological element of adherence, right? I know that I am so susceptible to believing somebody if I get along with them.
Yeah.
Like, and I know it because I'll come home and I will say to my Swedish, very scientific wife, I'll say, I had the best interacting with this doctor or whatever it was. And if she asks me why, I'm very unconvincing. I can't remember anything they really said or why it was so clever, but I felt at the time they really knew what they were talking about.
Yeah.
And I will go and adhere to their treatment recommendation accordingly.
Because of trust.
Yeah, because I felt like they... But I just wonder whether there's a downside to that as well, right? Where actually some of this needs to also be kind of verified and objective and...
I mean, some people are just very convincing even though they're completely wrong, right?
Can I give one example, actually?
Yeah.
I work with a doctor at Corti, whose name is Lasse, who told me that he drank coffee right into the afternoon and evening, right? And I went home and said, it's absolutely fine, drink coffee all the way into the... Right? And maybe that wasn't actually good advice that I got from...
No, maybe it was bad advice, but I don't know. Yeah, you need to be critical about some of the pieces of advice you get. Even just because people have a medical degree, they can give really bad advice.
PhD.
Right?
Yeah, but talking about that and going back to AI tools, and they can also be very convincing about their answers.
Yeah, absolutely.
Absolutely.
And it's so, you get a recommendation and maybe you even haven't thought of it, and then you see it and it's like, true. That's probably right.
Now you mean as the doctor in this case, right? That you get
But also maybe as a patient.
Definitely.
Yeah.
It's really difficult as a layman to know what was good or bad advice, but you're always one. I find that I'm always judging the doctor in the moment. Do I actually think that what they're saying is correct? Especially as I think you get older and you just accumulate more experiences of healthcare professionals like any other human also making some mistakes. Then you become a little bit more skeptical when you're talking to somebody. And honestly, I didn't trust your terrible coffee advice. But there's something in that we also do want those consultations to be more objective, and we do want patients to be able to go home and make a sort of critical decision about the advice that they were given. So do you think that conflicts with what we're talking about the kind of the charisma and the psychology of the moment? Yeah,
well, I've people have been talking about patients showing up with preconceived notions of what's to be done and not to be done, and that can be problematic for sure, right? I've definitely seen that also. If you've given examples of, but also have seen examples where it was really good, right? Where the patient comes in super prepared, and they just know what I'm talking about, and we can sort of better connect. So I think it should be possible to find ways where patients can use AI technologies to prepare, right? Both in terms of giving the information and that they want, if they want to chat for an hour, that the doctor might not have time for, it should still be possible to sort of just tell it all, right? And then the doctor could find a way to sort of condense it, right? But also to prepare, like to get some tailored information without a diagnosis, right? Because that's what the AI tools that the general public has available, they really love giving this overconfident diagnosis. But they also have this incredible amount of knowledge and ability to think broadly, right? That could also be harnessed. So I don't know how to do it, but in general, well-educated patients who have sought information is in general really good. Also sometimes catch things you might forget, right? It's nobody's perfect and the hospital system's not perfect. And if an admission goes on for a long time, the longer time and the more complex everything, the more likely that you're sort of, some things could have been done more, done better, right? And in that case, I've seen more than one case where it was helpful that the patient or family would ask questions. What about this thing, right? It can definitely. I think you're nodding. It can be helpful to have them.
Yeah, but we still need them to go to the doctor.
Yeah,
because we have problems just in Denmark getting, especially men going to the doctor.
Yeah.
And we cannot have a situation where everyone's sitting at home and being their own doctor.
No.
Because then we will miss all the things Vanessa also was pointing to before with the symptoms, right? They should be the right symptoms. So when you're asking the right questions and getting into the conversation, maybe it will shift a little bit or get nuanced. Yeah. So we still need people to go to the doctor.
You can imagine a situation where you're sitting in general practice and the patient comes in with bacterial pneumonia, not very severe. And then you have some kind of agentic, high-tech reasoning system that really digs deep and thinks, well, could this also be? And then lists some very serious things and that leads you to send the patient for a CT scan or I don't know. And then CT finds some kind of little nodule, maybe something a little bit of haziness or whatever that leads to a follow-up CT and maybe leads to that you have to actually refer to the pulmonologists and then you have to do a biopsy and you get this spiral and maybe nothing was wrong because we know that's how it is, these diagnostic cascades, right? Sometimes diagnosis is good, sometimes it's bad, right? So you could get these cascades started perhaps if you have a system that lures you to go down these routes when actually it should just have used your clinical judgment and treated it as a pneumonia and the patient was fine. So you could interfere with really good clinical judgment. That's a risk.
Yeah. And then from the economics side of you, that's maybe leading you in not very good direction.
Spending more than There's something as well that you three talked about, which is we've talked about this doctor who's gone to Google, and I feel it every time someone wrote that, I can go to Google. Like, why are you going to Google? But then, of course, in reality, it's not me going to Google. It is a healthcare professional, someone with experience, very different. They interpret the information much more cleverly. But you wrote in there about like the medium matters. I don't know whose example this was, but that there are examples where if somebody then goes to a textbook, it looks very legitimate and scientific and so forth. So then, okay, great, they really care. They're putting the extra effort in. But if it's Google, then it's...
Yeah. You gave the Google example, right?
Yeah. I think my example was you cannot know everything. And what you were saying, if you have the right eyes and the right mind to interpret that information, that's good. So you can double check if it's the right amount of blood samples, or you get you can go into a guideline and just double check if you are on the right path. But if you're not educated and you're not a healthcare professional, then you can just misinterpret the whole information. Yeah. And I think also my example was, it was when I was a young girl, I saw this doctor Googling, and it was the feeling of, oh, you don't know anything about this. And that was the wrong feeling, because she knew, she just double-checked something, maybe a prescription or something, I can't remember. But it was the feeling for me as a patient, like, oh, I could maybe just Google this myself. But you can't. You can't that.
And then the reverse of that story was when I was in general practice, a patient I had referred to a dermatologist came back after having seen this dermatologist, and he was like, this was a great dermatologist. He looked at my rash, and then he took down this huge textbook and started looking in it and finding out some very interesting things about my rash. And he considered that very positive, like looking for information. That's sort of the medium sort of matters, right? That was very interesting contrast.
Even if, like, today you might think, okay, that's a textbook that's been written and printed at some point. Perhaps it's no longer, up to date, but there's like a legitimacy, there's a weight to it that it's...
That's a good point, actually. Google might sometimes be better than a dusty old textbook, right? Yeah.
It seems to be that's, I think, one of the key themes also for people building in this space is that it's not as... the doctor-patient relationship isn't this, like, facts-based scientific process on one side and the patient on the other. It is ultimately just like a meeting of two minds and two people trying to come together with to come up with the right treatment plan, one person representing the one having the experience and the other person and who also needs to take the pills or do the action or whatever it might be, do the exercise, whatever it might be, and the other person who has the ability to interpret the science, so to speak. And it's just a different dynamic to the experience you mentioned, Laura, when you're younger. I also thought, okay, so doctor, so that's like an oracle. That's like somebody who knows everything and now is going to tell me the answer to my problem. And it's only through time you realize, oh no, it's a human being guessing, right? Based on some knowledge, right? Yeah. And some things are easy to guess and easy to answer, and other things are complicated. So with that in mind, then when that person researches a little bit, it feels like almost indulgent. It's nice that they're really putting the effort in.
Yeah.
That I think one of you wrote as well that the medium matters a lot, and in the same way that we don't want to interact with a doctor who is behind a screen, but we do want them to be documenting perhaps live because we want to make sure that all the information's caught.
Yeah.
How do you create technology that does both of those things, right? Ambient scribes being a great example of that, where there's no information lost, but at the same time the doctor's attention is fully on the patient. Yeah, we need ways to... I'm not yet ready for my doctor to be using ChatGPT, even if, I've been told many times that it's pretty remarkable and pretty accurate. I don't want that to be the authority, if you will.
No. I think it all depends on how it's used, right? Because as a cognitive aid to cover the edge cases also in your and cover the blind angles in your thinking and find out what else you need to discover, then it's super good, right? But if it's for replacing your thought, then it's not a good road to travel down. Completely agree.
Yeah, it's a tool, and if you're experienced enough and confident enough to use it, which means to know when to ignore it as well, then it's potentially very powerful.
But as it is now, the chatbots generally available, which are fantastic, I think they have some limitations for clinical use in them because they tend to just spew out confident answers. Even if they are getting better at it, I think some customized artificial intelligence products are needed to support reasoning better than what we have now. It's likely to lead to this atrophy I'm talking about, right? If you talk to the patient, write the EHR, and paste it all in to some chat prompt and get a diagnosis, then it's just so easy to do, and I don't think that's going to create these augmented clinicians that we all want to be. Need a different setup.
Do we need to get to a point where healthcare professionals themselves are building and designing their own tools? I'm just wondering what the next couple of years will look like, because if two opportunities we talk a lot about. One is the space of machine learning in general and what that's done to the kind of flexibility of tools, especially if you talk about agents. But the other topic related, the other big topic is vibe coding, and that people can increasingly build, I want an app that is really only good for me and my context and wouldn't otherwise be worth investing in software engineering because, it's only got one use case. I'm mostly thinking about that second piece on the kind of flexibility of...
You add a little bit of complexity and a large space of making things go wrong. If you say that clinicians should just build their own reasoning support systems, because as we're trying right now, hands on this, making some reasoning system to experiment with our agentic framework, it's really easy to not make it do what you want, right? It requires some thought and some experiments and some testing to make it behave the way you intend to make it behave. And I think with the systems we have now, it's I don't think it would be good to just say people should just build their own. But I would absolutely say that we should have clinicians involved in these things. And then some clinicians can definitely do it, but it should be for the dedicated ones. I don't envision a future where every doctor just sits down and vibe codes their own system. But I definitely see that we're approaching a place where we are at a place where you don't need an engineering degree to do this, but you do need a lot of effort, right, to do it. But it's well within the reach of clinicians to do, preferably in collaboration with some engineers, right, to get the validation right. I'd say
there's two extremes. There's everyone who's a clinician. If they want to use technology, they have to just look at their own individual day-to-day and context and build something bespoke for that. The other extreme, which is obviously more common and historically more common, is that tech companies build solutions and hopefully it's useful for you and your context. Here you go. And then obviously everything in between. And so what is it that what's important to get right for technologies to actually be helpful in these contexts?
To involve clinicians. So it will match their workflow and their thinking and what they actually need, instead of something that can do all these incredible things. But if it's not what the clinicians actually wants, then it's just waste of time and waste of power. Instead of really building something that can make you a better clinician, make healthcare better. I think that's very important.
But surely hospital IT has always been built based on what clinicians have asked a tech company to build, right? Clinicians would be the ones who state these are the needs, and then tech companies build it specifically to those briefs, right?
No, I don't think so.
Why is that?
And I don't think many different kind of technology struggles with actually understanding the workflow and the reasoning of a clinicians, because it's some very special, maybe a room with closed doors, and you don't understand it if you haven't tried. I also think if you ask my family, they think they know what it is I have been doing before I was joining Corti, but they actually don't, because it's a very special world. I think many clinicians or healthcare people also get friends inside the hospital, and colleagues become more than just colleagues, because it's a very special place and situation you are in, and you don't understand that if you haven't been standing there in the room in the middle of the night, having that feeling in your body. I think it's very very special. Yeah. So no, you cannot build something you don't really know what are.
So Vanessa, the obvious question I'm going to come with you is, do you think, to me it sounds very hard for somebody who's not a clinician to understand the space well enough to be able to really build solutions, but you've joined Corti, right, with the intention of trying to be a part of that solution.
Yeah, and ever since I started, and I still say it, I just want to get into the head of the engineers because I just want to understand everything. But I think I won't, or then I would have to do an engineering degree. So yeah, we are vibe coding. I think is interesting, but still you need some understanding of what is actually happening. But I think another interesting factor is also, the different generations. Surely a more senior doctor or a younger doctor is maybe more advanced when it comes to the tech side, or just the general open mindset they have towards, adapting to a new technology. So I think that's also important to consider.
Do you three agree that marketing departments encouraging healthcare professionals to talk about their situations is probably the most important piece of the puzzle? Do you think that that's sort of like that podcasts like this is really the only way to solve these problems?
Well,
is that what you would suggest?
Absolutely, getting these conversations going, fantastically facilitated by someone like you, is very valuable. Absolutely. And since we are also embedded in the various tech teams and customer-facing teams, then having these conversations is very important. So this is not just us sitting here being recorded. It is actually also developing some ideas, and that is.
We haven't been recording, so that's
no. Okay.